Good afternoon. I am Dr. Doug Evans, Chair of the Department of Surgery at the Medical College of Wisconsin, and welcome to our weekly update on innovations and happenings in the Department of Surgery. I'd like to devote this very brief video to a response to a number of questions that have come in based on prior videos. In way of background, I am a surgical oncologist. Prior to coming to MCW 8 years ago, I was on faculty at the University of Texas MD Anderson Cancer Center for many years. My clinical practice has been devoted to the management of patients with pancreatic and endocrine tumors, and I have spent a great deal of time in the area of research and treatment of pancreatic cancer. There was a video that I completed a number of years ago on one aspect of pancreatic cancer that concerned the doctor-patient relationship, and specifically some of the questions that patients and their families frequently ask. And one of the areas I was asked to address was how to manage the question from a patient and secondly from a family member on how long I will live. And I mentioned in that video that frequently the patients will ask the questions that they are prepared to handle the answers to. So, for example, if a patient is still having difficulty dealing with a new diagnosis of a very difficult cancer problem, they may not want to ask a question such as, how long will I live? Yet, for example, if the patient is older and they come to the doctor visit with their adult children may absolutely want to know. They will obviously be concerned about their parent who they love deeply. They'll also be concerned about issues related to their house, how they will get along, who will pay the bills, a variety of practical items for which more information is needed. I mentioned in that video that oftentimes family members need to be a little bit careful and allow sensitivity on the part of the patient as to how much information they would like to have. So, for example, a family member or two that comes with their mom or dad to an appointment, they may initially want to be a little careful in how much information they request, especially with regard to prognosis, as it may not be information that the patient themselves are quite ready to handle. We oftentimes say in medicine, as I mentioned earlier, that the patients will ask questions for which they are emotionally, mentally prepared to handle the answer. It's just something to keep in mind. When you do ask that question, either you hear it asked by someone you love deeply who is the patient and is asking the doctor how long I will live, or if you're meeting alone with the physician as a family member, a son, daughter of an affected parent, and you ask the physician how long I will live, just remember that the physician who is answering that question is doing their best to provide you accurate information. And what they are basically telling you when they answer the question of how long will I live is what would be the average survival of a patient who has X or Y treatments. So that remember, there'll be a large number of patients who will not be quite as lucky and won't live as long, and there'll be a reasonably large number of patients who hopefully will live orders of magnitude longer. Especially as our treatments are becoming much more effective, length of survival is increasing, and therefore those estimates by the physician will become a little bit more inaccurate. The answer to that question, if a physician does answer that question, the answer will be based upon the average anticipated survival of a large population of patients, which may be accurate or grossly inaccurate for a specific individual patient. Just something to remember. Obviously, as time goes on and we see how the patient responds to treatment, our ability to prognosticate longevity will become much more accurate. When we are inaccurate is certainly at the time of initial diagnosis, when it is very difficult to know what the future will bring. The second issue I wanted to address that has been brought to our attention recently is the whole issue of a second opinion. Obviously, we are huge fans of second opinions, and the more minds that can be brought to a medical problem, the better. That's especially important with regard to a cancer diagnosis. Here at this institution, we're blessed to have a large body of physicians devoted to each specific disease site. I think this is one of the obvious benefits of going to a large referral center where there is a, if you will, program devoted to almost every diagnosis that you can imagine, be it benign or malignant. We have a program in bariatric surgery, a program in gastroesophageal reflux, and foregut surgery, not only all this gamut of programs in cancer medicine. So that frequently, even though you will be seeing me, for example, or any individual member of our surgical faculty that now numbers almost 100, they will frequently, if not always, bring your problem, your case, as some would refer to it, to a multidisciplinary conference that is typically held weekly, where physicians of multiple specialties will re-review the diagnostic evaluation, all the laboratory studies, all the X-ray images. Those will be re-reviewed, discussed by a body of objective physicians who may not be as emotionally attached to you as a patient as would be hopefully your individual physician, and then generate a treatment recommendation. Certainly above and beyond that multidisciplinary review, a second opinion at another institution is always encouraged. Perhaps one word of caution in multiple opinions. Oftentimes patients can suffer from what I call analysis fatigue, or otherwise termed paralysis due to over-analysis. In other words, there is just a delay in beginning their treatment because of continued research and opinions from multiple other centers. When I see a patient who has oftentimes been to 4 or 5 other centers across the United States, for example, with a new diagnosis of pancreas cancer, it is unlikely that that 4th, 5th, or 6th opinion will bring additional helpful information to the care of that patient. Certainly that may not be the case with opinion number 2 or opinion number 3. So something for all of you to consider. Finally, I would like to comment a little bit upon the role of research in an academic medical center and its importance. The way I like to explain this is our advocacy, our commitment, and our intense dedication to not only the patient of today, but also the patient of tomorrow. Unfortunately, many of us will become patients of tomorrow. And if we focus all of our attention solely on the patient of today and do not have advocacy for research, clinical trials, bringing innovative thoughts from the laboratory bench to the bedside of the patient, we will not change our treatments for the patient of tomorrow. At many smaller hospitals across the country, there is appropriately an intense emphasis on practicing medicine as efficiently, as cost effectively, as free of errors and mistakes as is humanly possible. And that certainly is also the case at large academic medical centers. However, at most hospitals across the United States, there is no emphasis on research, innovation, clinical trials, and advancing, if you will, the care of the patients to be in the future, or as I term it, the patient of tomorrow. I personally believe that focusing part of one's overall medical portfolio on the patient of tomorrow will allow us to care for the patient of today even better. That constant quest, that unending thought about how to deal with a disease. For example, many of us spend almost every waking moment thinking about how can we treat pancreas cancer better in 3 years, in 5 years, in 8 years? What can we do? I would submit to you that that makes us better physicians to the patients of today. So remember that certainly when your physician is involved in a research program and you say to yourself, well, how will that actually benefit me? I would say that it benefits you by a mind that is crisp and focused on your disease virtually all the time, while obviously spending some of the time focused on patients of tomorrow. It's only through research, innovation, and discovery that we will develop better treatments for the diseases which we treat. For example, right now, many of you have heard of the advent of immunotherapy, something that never would have happened without an academic medical center industry partnership. The ability to focus multiple treatment innovations into a single clinical trial to look at window of opportunity for patients with more advanced disease, incredibly important. Benefit not only the patients of today, but also the patients of tomorrow. So hopefully this few minutes on a video helped to address the dilemma of asking and answering a question of how long will I live, provided some additional insight into how far to push the second opinion envelope, and also a little window into the world of research, innovation, clinical trials, and laboratory discovery that many of us feel is so important for advancing the science of medicine. Thank you again for listening.